We're delighted to have Professor Craig Shimasaki from Molecular Labs with us again. We've had him several times in the past. I'm sure you'll already know him. He's going to talk today about the Autoimmune Brain Panel, which is, and he'll be explaining that, the new term for the Cunningham Panel, and neurological symptoms, and in particular about CaMKII in neurodevelopmental disorders. So I think this evening, Craig, if that's all right with you, I'd love to leave you to introduce yourself. Is that okay? Because I do have a sort of panel of introduction, but everybody has already seen that. So maybe you could fill in the tidbits that are new as well. Or would you prefer me to introduce you as I always do?
I think that'd be good because that'll give me a little more time to add a couple of slides I've got here.
Oh,
So,
okay. All right. Will do.
so
Yes, well, Professor Shimasaki is a very honored guest who is the co-founder and CEO of Molecular Labs, a neuroimmunology precision medicine company, which is focused on identifying the underlying roots of neurological, psychiatric, and behavioral disorders triggered by an autoimmune response. He has a very, very long biography. He's just got an amazing background. He's an adjunct professor at the University of Oklahoma and has spent 35 years working in the fields of molecular biology, viral pathogenesis, and infection-triggered autoimmune neuropsychiatric disorders. So I think I'll leave it at that because he's just got such a superb long bio here. Anything else we can fill in afterwards. So Craig, I'd love you to spend as long as you wish to talking about the fascinating topic today. However, we will have time for questions at the end. And so please do put them into the chat or the Q&A, and we'll attempt to answer them all. Thank you. The recording, by the way, will be available on the website. Jill is asking that, so see you a bit later. Thank you.
Thank you, Jillian. It's a pleasure to visit with you and your colleagues that are listening to this webinar. So good evening or good afternoon, wherever you are from where we are, Oklahoma. Unfortunately, we've had about 23 tornadoes in the last 2 weeks. Fortunately, everyone here is okay, but I guess that's a sign of the changing in the weather. But what I do want to talk about is a different kind of storm. And so what we're going to talk about today is immune dysfunction and how they're connected to neuropsychiatric disorders. We'll focus a little bit more in particular on an enzyme called CaMKII, or calmodulin calcium dependent kinase 2, and its involvement in neurodevelopment disorders and the various biomarkers that are at least identified that have autoimmune antibodies that result in various types of neuropsychiatric symptoms. So what are we going to cover today? The first is we're going to talk about the biological connection first between infections, our immune system, and the development of these neuropsychiatric and behavioral symptoms. We'll delve back into a little immunology and a little bit of biology on those topics. And then we'll look at why is it that certain infections like strep and Borrelia, or otherwise known as Lyme, tend to be present in patients that have these immune-mediated neuropsychiatric disorders, such as PANDAS, PANS, and post-treatment Lyme disease. And then we'll talk about what is CaMKII enzyme and why is it important for normal brain function. And I think this is going to be an area in which we believe will show great promise, not only in better identification of these patients, but also future treatments. And then we'll talk about the biological targets or the biomarkers in the Autoimmune Brain Panel, which formerly was the Cunningham Panel, and how these can aid in the diagnosis of these patients with immune-mediated neuropsychiatric disorders, but also help guide therapy. And we'll briefly touch on some categories of therapy that have shown effectiveness in ameliorating these symptoms of patients with these types of disorders. So the disclaimer is that this content is for informational purposes only, and that the information provided is not intended to be healthcare or medical advice for any particular medical problem, but also it's not intended to substitute for you seeking medical attention from a qualified healthcare provider if you are a patient. So let's start with the biology. One thing that's really important to notice, and in a growing body of evidence, shows that inflammation and immune dysfunction has more significant effects on many chronic disorders than previously understood. And so this includes cancer, cardiovascular diseases, even Alzheimer's, which was thought to be more basically the tau and the amyloid factors, but we're seeing that there's an inflammatory response that precedes these and many others, including autoimmune diseases and neurologic diseases. Some people even believe that most chronic diseases are linked to chronic inflammation. So let's look at inflammation. So all inflammation is not bad. There's a difference between acute inflammation and chronic inflammation. So acute inflammation is the response to various things like infections, trauma, cuts, you see here allergic reactions, etc. And it recruits our immune system to be able to address, heal, repair. But what really is something that is not desirable, and that is chronic inflammation. And as you can see, what we're going to talk about and look at more focus is how the connection between infections, inflammation, the immune dysfunction, autoimmune diseases, and neurologic diseases. So if you look really, inflammation is our immune system's response to pathogens and injury. So this schematic shows that we have two different parts of our immune system. One is the innate immune system, and that's the first responder to any type of infection or any type of trauma or anything that is really our first defense. And then over time, our adaptive immune system, generally we're talking about weeks, kicks into play, but it's tied directly to the innate immune system, and the immune system signals the adaptive immune system to begin to do these things, including develop these long-term antibodies and immune responses to diseases and infection. So how does that occur, and what's sort of the mechanism between inflammation and our immune system's response to pathogens and injury? Well, as you can see in this slide, when we get injured or we get infected, our immune system has various types of cells that are a part of the innate immune system, such as the macrophages, the neutrophils, the dendritic cells that are in tissue that immediately respond to a foreign invader. And then they communicate with the other immune cells through the release of various types of chemicals and modulators that include cytokines and chemokines. And so in this graphic, what you can see is that there's various types of inflammatory cytokines and chemokines that are released from various immune cells that help recruit other immune cells. So if you think about this, it's the communication between the troops in trying to identify and ward off and recruit the rest of the immune system to a particular place. So you'll see and know about hearing about TNF alpha, other types of cytokines like gamma interferon, cytokines that are involved by the production of Th17 cells, such as IL-17 and others, and then even those that are produced by macrophage activation. So these are all important communicators that are a part of activating the immune system, both the innate and the adaptive immune system, to begin to attack these foreign invaders or help respond to trauma and get healed. Now, one thing to recognize is that our immune system, when it gets activated, what happens is you'll feel inflammation, fever, and many different things. And one thing that you might be familiar with is if you had, let's say, an infection with influenza A or B, um, the majority of those symptoms that you're feeling are not from the infection itself. It's from our immune system that's trying to respond to it. So, which is why drugs like Tamiflu are not given after 24, 48 hours of an infection, because that is not what's going on with all of those symptoms. So they'll give you symptomatic treatment, anti-inflammatories, things that'll reduce your inflammation. And another example is, let's say, Ebola virus. We know Ebola virus can be very deadly, but Ebola virus, people don't necessarily die from Ebola virus. What happens is they succumb to the immune system's over response and reaction, an uncontrolled response to the stimulation from these organisms. And we've seen a little bit more about this with the advent of COVID, or SARS-CoV-2. You've probably heard about the cytokine storm and the types of things that result in long COVID. So just so you know the connection between inflammation, the immune system, and infections. In addition, lots of literature showing that there's a growing recognition between the connection with our immune systems, the infections, and our neurologic and psychiatric behavioral disorders. And this shows here the number of anti-neuronal antibodies that have been identified over the years that have been involved in various types of neurologic, psychiatric, and behavioral disorders. So you may have heard of NMDAR receptor encephalitis, where antibodies are directed against the NMDARA receptor. You can see the GAD65, you can see others, which is the aquaporin 4, voltage-gated calcium channel receptor, and many of these. So there are more, and there are many that are being discovered. And these autoantibodies against different receptors in our body are the causative agents of these various types of disorders. So we come to the question, can infections really trigger neuropsychiatric disorders? This is a JAMA Psychiatry article published in 2019. And in this article, it was a Danish study of over 1 million individuals who were followed from birth to age 18. And what they found when studying these medical records was that if a patient was hospitalized for a severe infection, that their risk of developing mental disorders increased by more than 80% for the diagnosis of schizophrenia, autism, OCD, ADD, ADHD, personality and behavioral disorders, and many other disorders. So the editors published an editorial alongside the article and said, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? What they said was circulating autoantibodies that enter the brain via compromised blood-brain barrier bind to neurotransmitter receptors is a potential explanation, and this mechanism has been proposed in pandas and other mental disorders. So later in the talk, we're going to talk about certain anti-neuronal antibodies and the crossing of the blood-brain barrier and how they're correlated with various types of neuropsychiatric symptoms. So the other question is, simplistically, how does this occur, infections triggering these neuropsychiatric and behavioral disorders? Well, we already understand that we all get exposed to various types of microbial, viral, fungal infections. That's something that occurs almost on a daily basis. However, unbeknownst to us, often our body is fighting this off and doing things that will protect us. And so our body, through the adaptive and the innate immune system, begin to take care of fighting off these infections. And then this results in antibodies that are produced that will be identify and can identify these organisms should we ever again encounter them. Well, the problem comes in certain individuals that the antibodies that they make cross-react with certain neurologic receptors in their brain. This process is called molecular mimicry, and this is part of the reason we've named the company Molecular Biosciences, is because this is one of the underlying mechanisms that is a result of many of these different types of chronic disorders, and we'll talk about a few today. The resulting condition is the disruption of normal brain function, and then what might be thought of as friendly fire, in which the immune system is now attacking ourselves. So as these antibodies cross the blood-brain barrier and began to interfere with certain parts of the brain, particularly in the basal ganglia, you can see these neuropsychiatric symptoms that begin to manifest, which includes anxiety, aggression, rage, OCD, tics, and many more. And typically, patients will be treated symptomatically because they're treating symptoms. But these patients that are immune mediated are usually treatment resistant, meaning that they don't respond to the typical courses of psychotropic drugs. In fact, many of them actually get worse. Now, when these patients are placed on various types of immune modulators and anti-infectives and anti-inflammatory agents, we do see very remarkable recoveries in these patients. And it goes to show, because the underlying root of this is actually an immune-mediated infection-triggered disorder. So this brings us back to PANDAS. Many of you are familiar with PANDAS, but it's an acronym for Pediatric Autoimmune Neuropsychiatric Disorder associated with a streptococcal infection. And we're very thankful to Dr. Susan Sweeto, who took the time with her team to identify these patients and be very, very disciplined in identifying the different types of symptoms, the characteristics, the various treatments, along with a team of other researchers and clinicians. And the first paper that was published on this, the first 50 cases, was back in the late 90s. And she identified that the patients actually developed various types of OCD and other type of neuropsychiatric symptoms, but they were preceded with a streptococcal infection, hence the name PANDAS. So PANDAS and then PANS, which is pediatric acute onset neuropsychiatric syndrome, is very similar, but it doesn't have the strep component to it. It could be any bacteria or any organism. So there is a diagnostic criteria for PANDAS and PANS, and you can see that listed here. I won't go to it in great detail, but it does have to do with an abrupt onset of obsessive compulsive disorders, and then other types of neuropsychiatric symptoms that's listed here. And these particularly age of onset are in children. Now, this doesn't necessarily mean that adults or let's say other adolescents or older adults cannot have a biologically similar syndrome. It's just that they cannot be diagnosed as PANDAS or PANS because P stands for pediatric. And you can't have PANDAS if you don't have strep infection that's the root of it. So recognizing that there's an importance of homogeneously identifying patient populations to study, sometimes this has created a little bit of angst because the other criteria is acute onset. And so for PANS, pediatric acute onset, and PANDAS has an acute onset criteria. If it is what people might say gradual onset could be acute, they just maybe don't remember, or it's occurred over time. But categorically, you can't have PANDAS or PANS. So just a little background on that. You can see dysgraphia in children, meaning that they have difficulty with fine motor movements, and this is before and after a child who observed these motor tics. Another child who is drawing before and after the onset of PANDAS, PANS. But the thing I think that is very interesting, and that is history. And what we find is infection-triggered autoimmune neuropsychiatric disorders aren't new. So we're familiar with rheumatic fever. It's been described for a long time. But Sir William Osler described what he called these bizarre and percipitive behaviors in children with chorea minor, such as OCD and in Sydenham chorea. And we do know that group A strep is the causative agent of rheumatic fever, and about somewhere around 30% or so of these patients will develop the neurologic manifestation of rheumatic fever called Sydenham chorea. But it used to be called St. Vitus's dance, and it was because of all these choreiform movements that these children would have, loss of control of fine motor movements, loss of emotional control, and various types of things. So this, at one time, was called St. Vitus's dance. So let's move to the question of why infections like strep, Borrelia, tend to be present in these immune-mediated neuropsychiatric disorders. This is a list, not an exhaustive list, but this is a list of typical infections that can be and typically are present in patients that have these immune-mediated neuropsychiatric disorders. And there's a reason for these. Now, this, as I said, isn't exhaustive, but there is a reason because there's common sequence homology in some of these, which I'll show, that account for how this molecular mimicry can occur. So we'll take a step back for biology again, remembering that antibodies that are generated have to recognize a target. And these targets are called epitopes. So these epitopes are strings of anywhere from maybe 6 to 9 amino acids. And then they identify these on an organism, such as a bacteria, as you see here. But when they recognize and identify and develop these antibodies against an epitope, they then develop what we see through the rest of the immune cascade to ultimately produce what we call memory B cells. And these memory B cells are B cells that are producing a specific type of antibody that's directed against this particular epitope. And some of these memory B cells can last for a lifetime, which is why we get vaccinations. Some for different reasons don't last as long. But the goal here is to produce a lasting memory so that if you ever encounter this type of organism again, you don't have to wait 3 or 4 weeks before you mount an immune response. It's almost immediate because you've got circulating antibodies that are present. Now, the problem comes in when the antibodies that are made against an organism that has a common sequence homology to another part of our body. So let's say this antibody is being made to an epitope of a bacteria, and it's made against the epitope that has a common sequence to the, let's say, a neuron. Once that's made, then these will cross-react with each other, and we will see various types of cross-reactive antibodies, including what many believe, and we see that many autoimmune diseases result from. Now, why does that happen? Well, there's a lot of reasons why I believe that happens, because there's an immune dysfunction that's going on, that non-self regulation. And normally there's only 20 protein letter alphabets in the protein alphabet that we use. And therefore, at some point in time, there's going to be an identical sequence. And if it's made against that sequence, and it's common to another part of our body, like a neuron, you're going to get cross-reactivity, and it's called molecular mimicry. So we can think of it as friendly fire in the wartime. It's a breakdown when we can't distinguish self from non-self. And what we find is that in research, there are genetic factors that are involved with this. They happen to be the major histocompatibility complex, the HLA, class 1 and class 2, and what you may see in a majority of these individuals is that there can be, and usually is, a family history of some autoimmune dysfunction. It could be something such as psoriasis, asthma, lupus MS, rheumatic fever, other things that show that there can be and potentially are some type of genetic immune dysregulation potentially available. And then when you get these infections and they make antibodies against these common epitopes, you can see that they then develop these cross-reactive autoantibodies. So information has been published on molecular mimicry between group A streptococci and self-antigens. This is the carbohydrate that's there and attached to, let me see if I can get my piece here. Strep and M protein, there's about 100 different serotypes. Well, there's some common sequence homology between some of the M proteins and the heart valve. And hence, this is how we see strep-induced rheumatic fever, but also the neurologic manifestation being the Sydenham chorea, which then is attacking the basal ganglia. You can see joint manifestations of arthralgia, different problems with kidney, etc. So that's strep, but interestingly, there's molecular mimicry between Borrelia burgdorferi, which is one of the causative agents of Lyme, and the streptococci M protein. So there is sequence homology between the outer surface protein A of Borrelia and the M protein. And it's believed, and you can see that in studies, outer surface protein A from Borrelia burgdorferi and the common sequence between the epitope and the M protein on strep suggests that there's a role of molecular mimicry in the generation of these autoantibodies. And we do see that patients with Lyme, or what's called post-treatment Lyme disease, patients can have very similar types of neuropsychiatric and behavioral symptoms. And we find that they have very similar autoantibodies. Interestingly, this is not published yet, but it's something that we've identified through sequence searches, that from, in this case, the dopamine D2 loop, which is the dopamine receptor, and the D2 loop 2, that between SARS-CoV-2 or the coronavirus spike protein, that there's some sequence homology between the dopamine D2 loops and the outer surface proteins on the spike proteins on SARS-CoV-2, which can be one of the reasons that we see neurologic manifestations with certain patients that have been infected with SARS-CoV-2. So practical matters, this is just sort of a simplification of what molecular mimicry is. The two twins here that you don't get lunch, mom thought I was you and fed me twice. So let's move over to CAM kinase, the CAM kinase enzyme. What is it and why is it important for normal brain function? So first, let's talk about what a kinase is. So a kinase is just an enzyme that catalyzes the transfer of a phosphate group to another molecule, usually it's a protein molecule, and to regulate cellular activities. So what you can see is the protein kinase here, so there's many, and we'll talk about that in a second. And they take the phosphate from ATP, if you remember from your chemistry class or biochemistry or biology, and it gets transferred from there to the protein group, and the phosphate gets attached to it. Now, why is that important? Well, because it changes the function and the shape and the activity of this protein. So there's various types of things that they do. And then, as you would hope, there are also what's called phosphatases, meaning it'll take off the phosphate and either turn it back to its base state or turn it back to its resting state or turn it off. So simplistically, you can see here is that the addition of these phosphate groups by a kinase can activate a protein, or they can turn it off, or they can change its function, or they can make it bind to, because of the shape difference, to other groups of proteins. And this is a very important mechanism. In fact, there's over 500 different protein kinases encoded in our genome. And they play a regulatory role in nearly every aspect of cell biology. because they can modify the function, and they can alter biological activities, and they can even change transcription and translation, which is the expression of various proteins. And interestingly, there are hundreds of drugs that have been approved or in development that target these kinases, and you can imagine why, is because they're key for specific functions. And so many of the drugs are either kinase inhibitors or different types of kinase effectors. So let's talk about CaMKII. And CaMKII is just short for calcium calmodulin dependent protein kinase 2. It is essential for what we call synaptic plasticity, learning, and synaptic organization. But one of the other things is it upregulates the synthesis of dopamine, epinephrine, and norepinephrine. And so what you can see, CaMKII is also involved in the communication to these other receptors, GABA, NMDAR, voltage-dependent calcium channel, and many of these others, as well as transcription and translation. And this article says that recent studies suggest that CaMKII dysfunction throughout the brain may underline a myriad of neuropsychiatric disorders, including drug addiction, schizophrenia, depression, epilepsy, and multiple neurodevelopment disorders. So what we find is that serum autoantibody stimulation of CaMKII in human neuronal cells, which is what we'll talk about briefly, can be seen in patients with PANDAS and PANS. In fact, this is a publication that we and Dr. Richard Fry published, showing that in normal patients, CAM activity at 100, which is baseline normal, and elevated in PANDAS and PAN patients. And you can see various different elevations in these patients. So let's move to the biological targets in the Autoimmune Brain Panel, which formally is called the Cunningham Panel, and how these can aid your diagnosis and help guide therapy. And then we'll talk briefly about some of the categories of therapy that have shown clinical effectiveness. So some of the common symptoms that are associated, there are 5 targets that are looked at whether or not there are autoimmune antibodies in serum directed against dopamine D1 receptors. And so if they are, typically what we see is there's psychiatric types of symptoms associated with these patients. They could be mood swings, depression, irritability, aggression, delusion, and even psychosis. If patients have autoantibodies against dopamine D2 receptors, we typically see some type of movement clusters, movement disorders, choreiform movements. Sometimes they may be diagnosed with ADHD because they couldn't hold still, and sometimes with Parkinson's, we see that. If patients have antibodies directed against lysoganglioside GM1, we can see complaints of joint connective tissue pain and other types of tics. When we find antibodies directed against tubulin, which is highly concentrated in the brain, it is in other cells. And so it's not just this brain-specific autoantibody, but it is very highly concentrated in the brain. And when the blood-brain barrier is open, we see that it interferes with cognition. And typical symptom complaint is brain fog or different types of OCDs. And typically they're around food phobias, clothing, and intrusive thoughts. Then we talked about the calmodulin CAM kinase activity. When this is stimulated, and I won't go into the way in which we do this, it's a radioisotope assay in which we grow brain cells and incubate the serum on top of these brain cells. When we see that they're activated, patients typically have an activation of their sympathetic nervous system. So you'll see fight or flight behavior, such as separation anxiety, easily startled, mydriasis or dilated pupils, sensory sensitivities, etc. And often we can see that there's an infection, maybe of some kind, that hasn't been addressed yet. So these are why we identify at least 5 different targets, because a patient may not have all of these symptoms. So just because one is not positive or because 1 or 2 are positive, it just indicates that there is an immune-mediated autoimmune condition going on. Let me briefly go through a couple of case studies. And This is an 8-year-old girl suffering from many neuropsychiatric symptoms. So she had an abrupt onset, vocal tics, difficulty concentrating, and had urinary and sleep problems. This was her autoimmune brain panel. She had an elevated lysoganglioside GM1 and elevated tubulin antibodies, which correlated with her symptoms. She had a relapsing remitting symptom course. She was diagnosed with anxiety, OCD, and an unspecified disorder of immune mechanism. ASO titers were low, DNase-B were low, but normal IgG titers, so that didn't help. However, she had a significant recent streptococcal infection with high fever, sore throat, sinus pain, and cough, frequent ear infections, sinus infections, and idiopathic fevers. So strep can be identified in any orifice of the body, and also what you're looking for is there an infection that's associated with this? She had a history of positive mycoplasma infections, autoimmune disorders, frequent bacterial and viral infections. This was one that was caught early. And when they're caught early, that the patient was just treated for one course of azithromycin, rapid improvement in the symptoms, everything returned to baseline after 2 to 3 days. And you can see the anti-lysoganglioside and the anti-tubulin regressed back into the normal range. Another study of a 16-year-old girl who had OCD and tics, but also had this restrictive food intake. She at 11 started having this OCD, and we say food restriction because it's not an identity issue, it's an OCD issue. Fear of food contamination, fear of choking, but they still have weight loss. And so tics, poor concentration, sensory abnormalities, mood dysregulation, urinary urgency, etc. And in this case, they had to call the police 6 times to help because she just wasn't being able to be controlled. This patient, again, had one positive anti-neuronal antibody, which elevated the CaMKII. And again, you can see that there are different presentations. The course of illness was relapsing, remitting, and a sudden increase in symptoms whenever she was exposed to strep. She had previous diagnoses of autoimmune disease, not otherwise specified, and in cases identified with post-infectious encephalitis. So she was positive for Lyme, elevated mycoplasma, and Coxsackie titers, and you recall that those were some of the more frequent associated ones with common sequence homology. We didn't get history, and in this case, the family history had autoimmune disorders, including rheumatic fever, and the siblings had pandas. In this case, this was a bit more elevated treatment regimen of plasmapheresis and IVIG and symptom improvement. They maintained her with a low dose of Zoloft and then the ability to, or I should say, Abilify for maintenance. And the patient's then antibodies went back into the normal range. So the CAM is back to normal. One last one here, a 20-year-old female with OCD and neuropsych symptoms. I won't go through the details here, but you can see gradual onset of OCD and patient being 20 or so, depending upon where you would draw the line, probably wouldn't be a PANDAS PANS patient. Positive anti-dopamine D2 autoantibody and a positive elevated activation of calmodulin CaMKII. Relapsing remitting, idiopathic neuropathy, Lyme disease, and then the lab results were positive for strep, Lyme, Babesia, mycoplasma, EBV, and herpes zoster. And frequent infections since she was a child, positive for autoimmune disease in the family. This was one where they had to treat with 4 courses of rituximab, which removes the B cells, and then some ozone treatments, significant reduction in symptoms, and you can see all of her autoantibodies for both the dopamine D2 and the calmodulin CaMKII return to normal. So we have hundreds of these patient stories. This is Grace, who was diagnosed with ADHD and OCD. Actually, at 8, she was diagnosed with a mental disorder, wanting to kill herself. Parents emptied their 401k twice with no answers. We tested her. She was positive. She was treated. Her mom sent her this picture of her completely well, back to normal life and on the cheer team. Adam, who was diagnosed with ADHD, and they thought he had autism. They weren't able to contain him as much, and they were considering putting him in institution. They found out about testing, and we tested him. He was positive. He was treated for the immune dysfunction, and his mom sent us this picture of him running cross country, saying recovery is possible. He's 10,000 times better. So one thing that's important is that autoantibodies can target different receptors, and they can result in different symptoms. And so it's the reason why we do look at these 5 different targets. And the report guidance that we have is that if any one or more of the 5 assay values are elevated, it can indicate a clinically significant autoimmune neurologic condition. So it's important to recognize that the CAM could be positive, the dopamine D1 or 2, or just tubulin, but they'll be associated with these symptoms, but it doesn't necessarily mean that any single one has to be positive in order to indicate that this is likely an immune-mediated autoimmune neuropsychiatric response. Very quickly, we'll talk just briefly. There's a published study here looking at pre and post-treatment to see how well the presence or absence of these antibodies correlated with symptom presentation. And this publication was done in conjunction with a dozen different physicians and their patients. What we did find was that they fell into 2 groups, those that actually improved and those didn't improve after treatment. So there was no difference in those groups as far as the number of different types of infections. As you can see, the majority of them had multiple infections, and many of them that we described. So we looked at before they got treated, all of them had 1 or more autoantibodies positive and at different levels. Severity does not necessarily correlate with the elevation because there's differences in the avidity and affinity of these antibodies, but what you can see is that 1 or more of them are positive. In this group that responded to the treatment, again, this wasn't a treatment study, but it was looking at the correlation between that. So these are patients who were improved or completely got well. This was their post-treatment results, and you can see a dramatic shift in the presence and the elevation of their autoantibodies, which correlated to an accuracy of about 86%. And with an algorithm, we're able to bump it up to 90%. The goal is to continue to study, are there other types of targets that can help identify more of these patients? But we did see a direct correlation with the presence of symptoms and these antibodies, or the absence of them and the remission of symptoms. If you'd like, there are other published studies with patients who are diagnosed with schizophrenia or autism or other types of disorders. But again, remembering those disorders are diagnosed principally by clinical symptoms, not by underlying etiology or biology. So some commonalities in patients who test positive for the anti-neuronal antibodies in our autoimmune brain panel, or what we call the Cunningham panel. They typically are treatment resistant to standard neuropsychiatric drugs. They usually have had some frequency of infections. These can be even subclinical. They may have had neurologic Lyme or post-treatment Lyme disease. Often they'll have a family history of autoimmune disorders. They may have sudden or rapid onset, but again, it could be gradual. And we see sudden or rapid onset of OCD, potentially some restrictive eating disorders, vocal or motor tics and choreiform movements, anxiety, rage, separation anxiety, emotional ability, typically when we see a positive CAM, depression, developmental or behavioral regression, mydriasis or dilated pupils, relapsing, remitting course, suicidal ideation. In fact, one of the neurologists that we work with says that if you ask them, every one of them will tell you that they have had suicidal ideation, but you have to ask them in a way in which they'll respond. So this is why it's very important to be able to be sure that these patients get identified early in their disorder so that they can be treated. Of course, PANDAS and PANS, diagnosis and symptoms. So let's wrap up with what are some of the categories of therapy that have shown effectiveness for treating these immune-mediated disorders. Well, if we can group them together, we can put them into anti-infectives. Clearly, if you've got an infection, you want to find what they are, and you want to identify and treat those. Sometimes they don't identify the infection till after they're tested, and you find these antibodies, and then they go back and they look and they find them. Anti-inflammatory agents, sometimes steroid bursts, other types of anti-inflammatory agents. Medications or drugs or things that will modify the immune system, because remembering this is an immune-mediated disorder, and then there's a need to sometimes temporarily symptomatic treatment. And typically what has been said is that these are not the standard dose, but very low doses. There are also many allopathic and naturopathic treatments that fit into the same categories, and likely many have been identified that may indeed be helpful in ameliorating these symptoms. And I believe AONM has had Dr. Nancy O'Hara, who probably went through very detailed explanation of many of those. So in an overview, first is to treat the infections, identify the correct diagnosis, treat the infections, then provide symptomatic relief if necessary, treat the inflammation if it's present, treat the immune system and immune dysfunction. And then if you want some more information about PANDAS and PANS, there's a wonderful group of clinicians and researchers who published these papers in the Journal of Child and Adolescent Psychopharmacology in 2017. And there's actually four, but the three separate groups of them that identify the clinical management of these for the immune side of it, the infectious side of it, and others. And I'll just close with a couple of other studies. What you can see in this study is that antibiotic treatment for patients with infection and inflammation in this case, motor and vocal tics, or the Yale-Brown tic severity score. What you can see is patients that are in purple here, the reduction in the motor tics with septanir, much more dramatic changes in the vocal tics with septanir versus placebo, and then the overall the Yale-Brown Global Tic Severity Score. We mentioned some of these other treatments like IVIG and plasma exchange. This was a study published in the Lancet that showed treatment in the Yale-Brown Global, I think that was a tic severity score or obsessive compulsive disorder score. I can't read that one. But IVIG and plasma exchange compared to placebo. So what are the takeaways? If you're seeing these patients, be sure to obtain a thorough medical history, because you can find many of these things that were described in the history. And remember, gradual onset is not necessarily to rule out sudden onset, but it could have been many years ago and forgotten. These typically are relapsing, remitting. You see a family history of autoimmune disorders, sometimes restrictive eating disorders, weight loss, again, not classic anorexia. Irrational fears, things that are obsessional, choreiform movements, or these little piano playing finger movements. One of the physicians will say, have them hold their hands out straight, close their eyes, and see if their fingers are moving and they're unable to keep them still. Dysgraphias, which you saw, loss of fine motor control, vocal and motor tics, dilated pupils, a certain percentage of them you can see. Typically, when the CAM is positive, you'll see these dilated pupils. Some labs that you can do, strep test, ASO, DNase-B, again, if you're looking for strep. And even they say check the family members. ANA, which sometimes is positive in over 50% of the patients, looking for occult infections. Many of these, as were mentioned, and the autoimmune brain panel that we've mentioned here. So I'm going to leave you with these two TAC laws that I've adapted from Dr. Sidney Baker. Dr. Sidney Baker was one of the pediatricians that was involved with the Defeat Autism Now. He said, if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. And the treatment for TAC sitting is TAC removal. And the underlying takeaway here is search for the root and then treat the cause rather than treating the symptoms. And an important TAC law too is that if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms, meaning that these complex conditions are complex. So if you've got an infection-triggered, immune-mediated, inflammatory neuropsychiatric disorder, you need to treat the inflammation, the immune system, and the infection in order to be able to see resolution. So to be effective, you have to address all the underlying issues for resolution. So AONM, who is hosting this talk, and Molecular Biosciences, we provide free consultative services to healthcare providers on laboratory results. You can contact AONM at the website there or the phone number. And then we also have free in-service education for your staff or any of your office on these biological targets and how they can be used. There are free physician resources and publications and videos on our website. And there's free downloadable other types of educational brochures you can find at our website. So first of all, let me thank you because many of you are at the front line taking care of these patients. You're the ones who are taking care of them when often many other providers have not. In one of the studies we're about to publish pretty soon, we have seen that many of these patients have seen between 5 and 15 doctors before they get properly diagnosed. And so thank you for your work and what you're doing. And if we can be of any help to you or your patients, please don't hesitate to let us know. And I will stop there, and maybe we have time for a couple of questions.
Thank you so much, Professor Shimasaki. That was absolutely fascinating, and particularly the emphasis on CaMKII too. Can I just ask, we do sometimes hear of physicians who interpret the test as only positive if CaMKII 2 is up, and don't so much take the other markers into consideration. I know that that's incorrect, and you've just highlighted that beautifully. Is there a difference between the 4 of them and CaMKII 2 in the sense that CaMKII 2 is a bit more indicative of an active infection as against the others being more indicative of autoimmunity? And of course, one can have both.
Yes, so you're correct in that it's not just positive if CaMKII is positive. There are certain symptoms that are associated with CaMKII being positive. It is also, at least what we have found through numerous testing, that we don't know what the mechanism is, but if it's positive and highly positive, we see that there can be and usually is an underlying occult either infection or a recurrent infection that hasn't been addressed. So it's not a hard and fast rule, but we have seen that over and over again, and we're looking into the biology as to what we're doing that. But if any of the 1 or 5 of the 5 are positive, it's an indication that there's an immune-mediated response against some part of the brain.
Thank you. Thank you. We've received a lot of questions, so I'll just go through them probably sequentially rather than ordering them, because there are a lot. So first of all, in the chat, one of the questions is there a way to test for antitubulin? And of course, we see that one of the markers is for autoimmunity against tubulin, but could one answer this as a yes, that we are actually testing for antitubulin?
Correct. So one of the markers in there is tubulin. And as you saw that the tubulin antibodies, when patients are positive for antitubulin antibodies, typically the most common complaint is brain fog, cognitive complaints, different types of cognitive issues, focusing, concentration, things like that. And tubulin is an intracellular protein, and we actually get it isolated from brain cells. So it is very, very highly concentrated inside brain cells.
Thank you. Quite a few questions towards the end there, asking whether the panel can be used for adults as well.
Yes, in fact, initially we were testing just children, and over time we were seeing half of the orders that come through were adults, and they do respond to the same types of treatments. Sometimes they do take a little bit longer because, as you can imagine, the immune system is being primed for so long that many of these take a little bit longer, but we do have really good stories that have been shared with us about adults who have been positive, tested, and then treated, and effectively doing well again.
Thank you. Azad asks here, for children with PANS and possibly no clear infectious markers and elevated markers across all 5 categories, how can the panel help with identification of correct treatment?
Yeah, that's a great question. And this is something we're actually working on. We won a grant for about $500,000 to take the 15,000 patients that we have collected and clinically annotated with symptoms and working with treatments to be able to use artificial intelligence to be able to predict which treatments are associated with different types of symptoms and positives of different tests. So it is in development right now, and we're working on it. Part of the reason is even though it's $500,000, it still doesn't cover the actual cost for that. So part of what I do is go out and raise some additional capital so that we can do that. But that is the goal. And that is one of the ways we believe will be helpful. The other is that we do see patients being tested after some improvement to see if there's still autoantibodies present, and then either continue the treatment or slightly modify the treatment to other things that will get them back into baseline, which is how you see those case studies, is because that's what the clinicians were doing.
Thank you. One father here writes that he's used the Cunningham Panel here to detect that his son was elevated on CaMKII 2. He did experience a lot of skepticism. That was actually in Toronto on the Cunningham Panel, and resistance to do anything based upon the result. And he thanks your clinicians at the lab for all their help in getting the right assistance for his son.
Mm-hmm.
We do see this, don't we, from time to time, that there is, you know, sometimes it's ignorance, isn't it? It's just lack of knowledge of what the test is showing that leads to a difficulty in obtaining therapy in countries, you know, several countries across the world. Is that still the case in the States, or are things sort of thawing there?
Well, as we all know, medicine changes very slowly. Unfortunate for those with chronic disorders and those that are very debilitating and things, because science is at the forefront to try to identify and discover and understand what these are. But getting it into clinical practice takes years and years and years and lots of studies. In the meantime, the goal and the hope is that we can help take care of patients while that evidence is being generated. Now, there is evidence, and showed a lot of evidence, but the type of evidence that most, let's say, groups want to see, which is very important, is multiple peer-reviewed, double-blind, placebo-controlled studies that take lots and lots of money and lots of time, which at this point, you know, for us, we don't have that either. And as I mentioned, you know, even our testing doesn't cover our costs. So we always out raising money. But this will happen over time. And we believe that it will, because people are getting well. And ultimately, if something works, ultimately it will become. So it is a challenge, and I feel we work with lots and lots of parents and patients and doctors because of the dilemma and unfortunately some of the predicament that they're in. And it's just overwhelming many times. So many of the parents who are listening understand that. And the best thing is get with an advocacy group, get connected with us. Lots of groups in the UK and the United States that can help support and identify and get resources.
Yes, thank you. There is a mother here who says she's in the Mississippi area and desperate to find a physician who could help her son, or at least her child. May I suggest that she writes to us, and then we can direct her query to your lab, and you may have a doctor that you know of in the States in that area?
Yes, you can do that. And if you send it to you, we have over 2,500 doctors who placed orders. Some of them are more familiar with what to do. Some of them have done it because patients have requested it, but we certainly could be able to not necessarily recommend, but we can suggest those who are familiar with that and could be looked into as someone who would be more knowledgeable.
Likewise, AONM in the UK for another couple of queries that have come in from parents looking for assistance. We have in the past been hesitant about making recommendations, but we do now have quite a number of docs who we know and excellent therapists as well. And so do contact us on contact@aonm.org. Maybe Claire, you could put the link into the chat, because I can't remember exactly whether it's contact or contacts, but that would be a good place to connect with us, and then we can make some suggestions, which again wouldn't be recommendations, but just, you know, people familiar with the test who would definitely be able to hopefully take you some further steps on your journey. I'll just go to the Q&A now because I've been concentrating on the chat. One father here says, I missed the drug classes that work well for patients that have infection-triggered autoimmune neuropsychiatric disorders. One was immunomodulators. What were the other drug classes, please?
Yes, anti-inflammatory, because inflammation, again, is a part of it. And the other is anti-infectives, because you've got underlying infections that are stimulating the inflammation in the immune system. So again, these three components tied in with any kind of symptomatic relief that patients need are typically how you'll see these being administered in clinics that really know how to do this.
Thank you. And can you have a false positive elevated CaMKII 2 result? Another parent asks.
Certainly, I mean, you never say never about anything, but what we do see is that if it's elevated, they have some type of symptom. So because it's involved with the activation of the sympathetic nervous system, you would see some type of sympathetic symptom response. Now, whether or not, they're, let's say, PANS or PANDAS, that may or may not be, but it definitely would be something that's immune mediated, because studies have been published showing that when you remove the antibodies out of the serum, it will no longer stimulate the CAM. So it is an immune mediated response telling the CAM modulating CAM kinase to be upregulated, which again is involved in the synthesis of the neurotransmitters epinephrine, norepinephrine, and dopamine. And you don't want that to be just sort of increased for no reason.
Thank you. That makes a lot of sense. And another question related to exactly that. Do you see cases where the only enzyme that is elevated is CaMKII 2?
Yes, in fact, one of the case studies I showed was that. And often what we do see is if it's left untreated, the other antibodies will start to elevate if they're tested later. And so you'll start seeing the progression of these other symptoms. Because again, it's the immune system that's still just being stimulated.
Thank you. One doctor here asks, what kind of resistance are you experiencing from the pharmaceutical research organizations and the like, if you feel able to discuss that publicly?
I don't believe we're having any resistance from pharmaceutical or any of the research. I think if anything, it's the typical PANS, does it exist? Or is it real. And we could do a whole nother lecture on that.
Mm.
But the pharmaceutical groups also, and we're talking with some of them to be able to help them develop tests or treatments that could be directed towards these patients.
Exactly. Your test is absolutely perfectly primed for that, isn't it? Afifa asks, is low-dose naltrexone showing any use in immune modulating effects in pandas?
So many clinicians use low-dose naltrexone, which has a different purpose at the regular dosing for various types of drug abuse and drug use. But at a lower dose, the believed mechanism of action has some type of anti-inflammatory agent, and they have seen that there is some effectiveness with different types of motor vocal tics and some symptoms for pandas and pans. Again, this is not a recommendation for that, but if you look at many of the clinicians who are practicing and treating these patients, many of them will say, yes, they've used that, and they do see that in a certain percentage of patients.
Thank you. Another doctor asks, are there any particular polymorphisms which predispose to the expression of pans and pandas?
Yeah, so this is really interesting in a SNP or a single nucleotide polymorphism. Again, these are identified and found in the major histocompatibility complexes and the other immune genes. So there are groups that are studying this, and there are those that have identified. Again, these polymorphisms are like a predisposition versus an actual causation. So these are single nucleotide changes in the gene that have to be combined with many other things, plus the environmental effect, such as an infection or other types of causative agents. But yes, there are, and there are many of them. No causative agent is identified, but there are groups that have identified different types of single nucleotide polymorphisms associated with the propensity to develop pandas and pans.
Thank you. And one professor on the line asks, is this test a research test with an RUO certification or a laboratory developed test, LDT or FDA approved? That's a bit complex. You may want to continue discussing that with her offline, but
yeah, but the simple answer is it's regulated by Health and Human Services under the laboratory as a laboratory developed test. We've been CLIA inspected 8 times with no deficiencies. Actually, we've received the Award of Excellence. It is the current regulation for services, like all other laboratories and all hospital laboratories. However, we are working on a pathway for FDA 510(k) clearance when the FDA identifies that pathway. But it is not a research use only test. It's a clinical test that the results get sent to the doctors, and we're certified and licensed in 49 states.
Fantastic, thank you. Another attendee here asks, Dr. Cunningham told me several years ago she was looking for serotonin receptor antibodies. Is there any new information regarding that?
Yes. So her lab and our lab together have been looking at that. And we have found that both the serotonin receptors, a couple of different ones, 5-HT2A and 2C, and then also the serotonin transporter are potential. What we have found so far, again, this requires research dollars, but we have not seen those isolated that are different from maybe one of the others being positive also. It is the goal for us to add other markers, including a blood-brain barrier marker to identify how permeable is the blood-brain barrier, because these serum antibodies would need to cross the blood-brain barrier.
Okay, thank you very much indeed. A patient group with Ehlers-Danlos syndrome have, according to literature, clearly increased incidence of autoimmunity and psychiatric disorders. as well as the tendency to leaky gut and leaky brain. Do you have any recognition of that?
Well, it is, and that is true. EDS is associated and has been associated in a subset of patients that have HEMS and PANS. Again, EDS is believed to be an autoimmune dysfunction, and it is higher concentration in those patients that have these immune-mediated disorders. We are studying some of those patients too. As to the other question, the leaky gut, the leaky brain, it is one of the things that seems to be clinically correlative, meaning if you have gut dysbiosis and you have various types of leaky gut, the same or similar epithelial cells line the blood-brain barrier. And so the belief in sort of the clinical demonstration of it is, patients with these immune-mediated neuropsychiatric disorders will typically also present with gut dysbiosis, various types of microbiome dysfunction, and many of the other things associated with. So in general, there is an association with this leaky gut, leaky brain concept.
Right, thank you.
I might add maybe one other thing. It is the reason why many of the focuses do focus on trying to repair the gut early on, because in doing so, one, you don't get the foreign proteins getting into the bloodstream, but the other is that same type of treatment could presumably help repair the blood-brain barrier. And that's just sort of a presumption, but it just makes logical sense.
Yeah, it's the leaky vasculature, leaky brain, leaky gut connections, isn't it? Jill asks, how many laboratories run these tests worldwide? Are there any others, or is it just Moleculera?
Yeah, so we're the only laboratory in the world that runs this test. It's a high complexity test. We are not allowed through that for anyone else to run it. The other is because the test is a process and the training of the people and the procedures that are used. So all the specimens, including from other countries, come directly to our laboratory here in the Health Science Center. We do bill for insurance, and we do have CPT codes that cover them, and we do that on behalf of the patients. And often we will get reimbursement for that, and we'll cut checks back to the patients for that. The test price, I think, was asked. You can check with AONM. If you're in the United States, clearly we can bill for insurance codes. I don't know what the National Health Service and that is in regulation is in the UK.
Yeah, that's difficult here in the UK with the National Health Service, but some Bupa Global and so on, some private insurance schemes do cover it. There is a price tag to it because it's so specialist, as you've explained, and yet one has to weigh that against a child being, or indeed an adult being consigned to psychiatric medications for the rest of their lives, perhaps, and also having something in your hand that evidences a physiological issue rather than just psychiatric. I think you find that, don't you, all the time, that doctors, patients, practitioners are so grateful that you do exist. Thank you so much. I'm sorry, it's such fascinating questions that I hadn't realized how over time we've gone. I do apologize as well. I wanted to be mindful of your time. Claire, maybe you could attend to that. I've just seen one additional. Can you put the link to the lab in the chat? Maybe you could do that while I'm just talking about the additional webinars we have. I do want to just say that you can find details of this tremendous test under PANS Pandas on the AONM website. So all you have to do is go to AONM, that stands for the Academy of Nutritional Medicine.org, and you'll see a tab there, PANS Pandas, and all the details and the contacts are there. But if you'd prefer, do just contact AONM at info@aonm.org, and we have a wonderful helpline that will immediately give you lots of information. And I'm always there to help make the contact with Professor Shimasaki and the others at the lab once you've done the test. And even in many cases, they're kind enough to give advice before you've done the test, just to sort of work out whether it really does seem appropriate or not. So just to mention, Craig, do you have time while I just briefly announce the upcoming webinar?
Sure.
I do realize we've gone over time. Sorry about that. We do have another webinar upcoming on the 18th of June. That's a Tuesday at 7 o'clock with Professor Leona Gilbert, Dr. Armin Schwarzbach, Dr. Prutineo, and Mr. Berger from Armin Labs. And it's called The Immune Response to Lyme Borreliosis, a slightly longer title. I mustn't leave out terms because they're all important. Adaptive Immune Response Investigation in Lyme Borreliosis. So we're very much looking forward to that. And we do have many other webinars planned for this year. So please do keep on looking at our events tab on the website because they'll all be up there. Thank you so much again, Professor Shimasaki. That really was tremendous. Very, very fascinating.
I just close with,
yes.
Yeah. So first of all, thank you, Jillian, and your work at AONM and helping patients and doctors be able to get access to the testing, but also to provide the support. We also want to just say to all those out there working on this area, one of the parts of our mission is to give hope to people. As long as you have hope and you can continue to persevere and look for answers, there are things that will become known and available. And part of that is really why we started, that's the start of the company, because of the need. Most companies start with lots of resources and finances. We don't have that. So we try to do what we can to help everybody, but we do believe that this will help change how medicine is practiced over time. And that's the goal, because many things occur in medicine that people don't know about. Long COVID is one of them. There are many things that are still out there. When I worked at Genentech, it was HIV came out, and we had no clue what AIDS was. And so there are many things that will become known, and this is one of the areas that we believe will impact probably many other chronic disorders, including one that we're working on with Dr. Madeline Cunningham for the Autoimmune Cardiovascular Panel. And because of her early research for many decades, these target identified that we're able to perform and run and be able to continue to do our research on. So we're grateful and thankful to her and to many of the other doctors and researchers around. But thank you, Jillian, for your help in sharing this with others. And we're happy to help and work with you in any way that we can.
Well, thank you so much. It's fantastic to have such a dedicated laboratory and team for this hugely important disorder, which brings tears to one's eyes all the time. The stories one hears, it's just you're doing tremendous work. Thank you. And thank you everybody for being with us this evening. And please do just write into us, contact us if we can help in any way at all. Thank you. Thanks very much. Bye-bye.